Good morning, Dr. Hill.
All right. Good morning, everyone. So I was just going through the Jeopardy sheet, and I think what we need to do to make it even, we'll have three people play this week or next week, then three more the week after that, and then we'll be into the semifinals. So let's see. The people that are playing Jeopardy this week will be Joseph Ravago. I see you there. Let's see, Daniel Reeves. Do we have Daniel today? I do not see Daniel. And Jacqueline. I also don't see Jacqueline.
I'm
Hmm.
here.
Let's see. Oh, there's Jackie. Okay. Will you be able to play on Tuesday morning, Jackie?
Yes, I will.
Okay, perfect.
So I
All right.
don't take the quiz today. I don't take the one.
Exactly. Yes. So Joseph, Daniel, and Jackie, if you three will not take your quiz today, then you'll take quiz live on Tuesday morning, and I will send you three an email right after class to remind you. All right. Does anybody have any questions before we begin? No questions? Okay, so today's a really short class. Unfortunately, it's the last of the short classes. The remainder of our classes will be quite long. So I'm just hoping to give you a little break this week. So coming up next week, we will be talking about sex offenders, then mentally ill offenders, then gang members. And then we're going to have our last lecture is about desistance from crime, which is like the opposite of recidivism. So quitting crime. So the next couple of lectures are going to be very heavy and quite lengthy. So let's take advantage of this short lecture today while it lasts. Okay, here we go. Okay, can you guys give me a thumbs up? You see the lecture? We're good? Okay, very good. All right, so what we're gonna do today is just finish up the lecture on drugs. So we already talked about drug courts earlier in the week. We talked about the components. We talked about how effective they were. Again, just a quick reminder, when I'm talking about drug courts this week, I'm talking about adult drug courts. We see differing results for juvenile drug courts. Juveniles generally respond quite differently to treatment than adults do. And like I said, if you're interested in that, I believe Dr. McNamara teaches a juvenile justice class where he focuses more on that. Then we started talking about the treatment modalities. Remember, a modality is just a fancy word for category or type. And on Tuesday, we talked about detox and methadone maintenance, both of which are strategies to reduce your physical addiction to drugs. But we also have the mental addiction that we have to deal with. So today, what we're going to talk about are the two therapies that we have to address the mental addiction to drugs. All right, so we're going to start with outpatient drug-free programs. Now, when we talk about outpatient drug-free, just keep in mind that this is like mashing a million different types of treatment into one. I would probably be upsetting people that focus on this type of research or therapy by mashing it all together. But for our purposes, that is what we're going to do. If you're interested in the different types of, psychotherapy and group counseling and different ways to talk through these mental issues, or your mental addiction to drug addiction, that would be a class for the psychology department, or maybe even sociology or social work. But for our purposes, we are mashing them all together. So outpatient drug-free programs are the most common. About 60% of drug abusers who are in treatment are in this type of treatment. And this approach is an intervention that utilizes a wide variety of non-maintenance programs. So when I say non-maintenance, that means we're not using drugs. So it's not like methadone maintenance. It's not those types of drugs that you can take along with it to sort of curb your addiction or to block those receptors. So if you do shoot up heroin, you don't feel the same effects. So outpatient drug-free, when we're talking about that for our purposes, this is some sort of talk therapy, whether it's psychotherapy, group counseling, individual counseling. It just means that you are talking to a therapist about the issues that led you down the path for towards drug abuse. And it's considered outpatient, not inpatient. So outpatient means that you are not living in the facility where you're receiving treatment. So if you are living in that facility, that would be an inpatient type program, or it's also referred to as residential, meaning you are actually living in the place that you're receiving treatment. So you can have outpatient drug-free therapy in an incarcerated setting or in the community. If you're in an incarcerated setting, that just means you're in the general population with the rest of the inmates, and then you go to a different wing of the prison or into the therapist's office or into like one of their rooms where you can have group therapy. This is contrasted with the inpatient or residential type of therapy that you can get in a prison. We're going to talk about that on the next slide. Those are referred to as therapeutic communities. So if you're doing outpatient drug-free programs in the community, that just means you're living at home and you're going to a treatment center or to a therapist's office to receive your treatment, meaning it is outpatient. So like I said, there's quite a bit of variety about how these programs are implemented. They include anything from very demanding daytime therapeutic community type meetings towards to more relaxed programs. So some outpatient drug-free programs might utilize psychotherapy and have you come 5 days a week. Others just have you do group therapy sessions, once a week. And each therapist and each sort of type of program that you can go to has their own way of sort of drawing out the issues that led you down the path of drug addiction. But like I said, for our purposes, we're just mashing them all together. The primary focus here is to counsel and train drug abusers.
Dr. Hill?
Yeah.
I noticed this might be a typo in the slide, but it says, and train drug abusers too, they can improve their social skills.
Yes, you're right.
Shouldn't it be so?
Thank you, Stephen. Yes, I'll change that. So what we're hoping to do is to improve their social skills and to improve their life circumstances so that they don't go down the path of drug abuse after this treatment. What we're trying to do is help them recognize the life circumstances that fostered their drug abuse in the first place. So that's talking them through a therapy they had as a child. Sometimes some of these therapists can use hypnosis as well. It's not very common, but it is one way that they can address these issues. So you're trying to figure out sort of what life trauma led you to this drug abuse in the first place, and ways to deal with that moving forward. So this is the main difference between those detox and methadone maintenance programs. This is the type of treatment that helps you address your mental addiction to drugs. So we're trying to find out why you started using drugs in the first place. And at the same time, we're trying to improve your social skills and improve your lifestyle so that you don't slide right back into this as soon as the therapy is over. So a lot of times what you're trying to do is receive this sort of outpatient therapy while you're in methadone maintenance treatment, or at the beginning, you might do some detox and then go into outpatient drug-free programs. Either way, you want to use these two together so that you can address your physical addiction and your mental addiction to drugs. So, therapeutic communities. This is contrasted to the outpatient. This is an inpatient, this is residential, and these are the programs that are offered specifically in prison. So if you're doing inpatient in the community, you are living at a residential facility, whether that be at a treatment facility, somewhere away from home. But if you are in an incarcerated setting and there is an inpatient residential program, chances are it's a therapeutic community. So this is a general term referring to residential self-help drug-free treatment programs that are offered to people in an incarcerated setting. So the goal here is to partially isolate the offender from the rest of the correctional population. You don't want this person in the general population. You want them isolated so that they can sort of help each other and motivate each other. But also, contrary to popular belief, there are quite a lot of access to drugs in an incarcerated setting. They are smuggled in all the time. So what we're hoping to do is to move these people out of the general population where drugs are more readily available, so they can work on getting clean and they can all motivate each other as well. So by having them away from the general population and living together, this increases group pressure to commit to the program and decreases the peer pressure where they would be if they were in the general population, they might be receiving some sort of peer pressure to do drugs if they were available to them. You're also hoping to decrease the peer pressure to have that lifestyle that is associated with drug use. So like I said, this is another form of talk therapy, and we're trying to change the lifestyle of this person so that they don't go back into drug abuse as soon as they get out of prison. So these therapeutic communities are premised on the belief that effective treatment for drug abuse has to occur in a 24-hour residential living environment, so that instead of living in the general population surrounding by those types of people that do participate in drug abuse, this way you can receive your therapy during the day and also be living around a bunch of people that are committed to kicking their drug habit. So we're assuming here that stable recovery from drug addiction depends on the successful integration of a variety of social and psychological goals. So the psychological goals are achieved through the therapy that you're receiving, and the social goals, again, we're going to isolate you away from the rest of the population so that you can all try to maintain a pro-social lifestyle together. So we're trying to change the lifestyle of drug addicts and help them maintain abstinence from illicit or licit substances. Illicit substance would be something like alcohol or drugs that are prescribed by a provider, but if taken out of context, can lead to a drug addiction. So we're trying to eliminate their antisocial activity that usually fosters drug abuse. And also we're hoping to increase their employability and instill pro-social attitudes and values. So generally they're going to fill this person's day with drug treatment, but we're also going to, again, like I said, try to change their lifestyle. So they might offer GED classes or maybe some college credit, or adult basic education, or maybe a vocational class here or there. But basically we want to fill this person's day with ways to sort of improve their lifestyle so that they're less likely to slide back into a life of drugs when they get released. So just like the drug court that we were talking about before, a lot of therapeutic communities have several phases that you go through. And we have this strict hierarchy and we have this insistence on rigid adherence to norms, and we're using the peer pressure of everybody in this therapeutic community to make sure that this person is doing the things that they're supposed to be doing throughout the day. So the client usually progresses through several treatment phases, and as they progress through these phases, you have increasing levels of responsibility. So once you progress most of the way through the treatment program, usually you become a mentor for the people that are just coming into the program. You also usually have the treatment staff is usually a group of people that are ex-drug addicts, so they know where you're coming from. So it's easier for them to talk to you. And a lot of times these people take them more seriously. It's hard to take advice about kicking a drug habit from somebody that's never been addicted to drugs. So usually the treatment staff are people that have overcome a drug addiction. So generally the activities that you do throughout the day in a therapeutic community usually would be usually you have morning meetings. Then in the afternoon, you'll have either individual or group therapy with your treatment staff or your therapist. They have life skills groups. Like I said, we really want to change the lifestyles of these people. You can participate in all different types of treatment programs, as well as educational, vocational. It really just depends on the institution and what they can provide for this person. They also might have additional services related to family therapy, physical and mental health. So a lot of times people's like tumultuous family situations led them down the path of drug abuse. So you might have family therapy in the prison to help you with that, as well as physical and mental health. One of the things we're going to learn about in 2 weeks is a phrase or a term called co-occurring disorders. And that just means that you have a drug addiction and a mental health disorder as well. So that's why we often see therapeutic communities also include mental health treatment as well. It is extremely common that people that have either a mental disorder or a substance abuse problem have them together. So if you address one but not the other, you wind up sliding back into those same issues as well. So sometimes these therapeutic communities, will, more often than not, they will also offer mental health counseling as well. So we have these community norms. They're emphasized and reinforced with clear rewards and clear sanctions intended to help develop self-control and responsibility. So it seems a little silly to offer them these clear rewards, but I saw how helpful this can be. So when I was watching or when I was witnessing or observing the cognitive behavioral classes here in Charleston County, right by the jail, it seemed silly to me. They had a lot of little rules, and like, you know, if you were on time, you got a sticker. If you got 5 stickers, you got access to like a snack bin. Or, you know, they would have daily raffles where you might be able to win, you know, a $5 gift certificate to the dollar store, which seemed kind of silly for me, but these guys really loved it and they responded really well, and it kind of hit me. I grew up in a lifestyle where I was given structure. These guys have never had structure. So for them, it was very comforting to have the structure and to get these little rewards. So it's kind of the same thing here. They have very rigid norms and they give them little prizes throughout the day or, you know, up their responsibility. So it's something for them that's very helpful. When you grow up in a chaotic environment and then become a drug abuser, that's also very chaotic. So just having a structure and small rewards means a lot to these guys or girls. All right, questions about therapeutic communities before we start talking about what the research says? All righty. So let's, the next 2 slides that we have talk about the effectiveness of incarceration-based treatment and then the effectiveness of community-based treatment. So starting with incarceration-based treatment, there's been quite a bit of research on this. Most of the research compares therapeutic communities to just regular outpatient drug-free programs in an institution, or sometimes what they'll do is compare therapeutic communities to the 12-step programs like Alcoholics Anonymous, Narcotics Anonymous, so on and so forth. But most of the evaluations have focused on the therapeutic communities notated as TCs here on the screen. So what we've seen, there have been quite a few meta-analyses on these. They've generally shown that the therapeutic communities exhibit the strongest and most consistent reductions, both in drug relapse and recidivism. So one evaluation of the therapeutic communities found that they reduced recidivism, had a modest effect. So those in the therapeutic communities recidivated at about 43% compared to their comparison group, which recidivated at about 50%. So the first thing to note about it is that therapeutic communities seem to work the best compared to outpatient programs or the 12-step program. So that's the first thing that we can garner from this research. The other aspect that's important about incarceration-based treatment is including an aftercare component. So there are mixed results about the aftercare component. So aftercare generally just means when you are released from prison, you continue your treatment. But the results are mixed because some people consider aftercare being a requirement that you just go to a 12-step meeting once a week. Others say you need to go to a very structured group therapy or individual therapy program, 3 to 5 days a week. So the fact that there's such variability in what we consider to be aftercare is why we have some mixed results. Some studies show that aftercare doesn't seem to make a difference. Other studies show that it does seem to make a difference, but that's mainly because there's sort of a not clear understanding on what we're considering aftercare. But the primary goal of aftercare is just to provide a continuity of care that help maintain the behavioral changes, the foundations that we've set in this therapeutic community. So in general, what the research shows is that therapeutic communities work best, and then when coupled with aftercare, that can add an added layer of protection as well. So who wants to turn that into a policy implication? We can practice for what we know is going to be our 5th question on our quiz this week. All right, Stephen, let's hear it.
I recommend that aftercare programs be used to help people overcome their drug addictions.
Yeah, that'll work. I would recommend you probably want to focus on the therapeutic community modality, but you could put those two together, or you could just say have one for aftercare and one for therapeutic communities. All right. Now let's talk about effectiveness of drug treatment in the community. So this all started during sort of the 1980s. So drug treatment for offenders in the community resulted with coordinated efforts by some states to divert drug abusing offenders out of the criminal justice system and have them in the community receiving treatment, but still be controlled by the criminal justice system. So during the 1980s, during that sort of get tough movement when control and surveillance kind of became the focus here, interest moved to programs that required offenders to participate in treatment as a condition of probation and parole. There's a number of reasons why they did this. First of all, the inability of the criminal justice setting to provide adequate treatment. So even though we do have therapeutic communities and some outpatient drug-free programs in an incarcerated setting, research has consistently showed that if you give this person treatment in the community, they're going to respond better than treatment given in an incarcerated setting. There's a couple of reasons why this is. First of all, if you're giving them treatment in the community, they are not surrounded by other criminals. So they're less likely to fall back into that lifestyle if they are surrounded by more pro-social people in the community compared to an incarcerated setting. Another reason why treatment in the community works better is because they have the support system of their family, if that's a good thing, or of their friends, if their support system doesn't exist for their family, and that might be why they're doing drugs in the first place. but you're more easily able to access your support system in the community than you are in an incarcerated setting. And the third reason is because just generally the quality of treatment is better on the outside than it is in a prison setting. For the most part, prisons are located in the middle of nowhere. Usually when I drive to a prison, I'm driving at least an hour and a half, sometimes 2 hours. And more often than not, I have to screenshot the directions before I get off the interstate, because usually the last 30 to 40 minutes of my drive, there is no cell service. And when I go to Wateree Correctional Institution, not only do I not have cell service, but I can't even be listening to music because my phone isn't working. I'm trying to listen to the radio and it's just straight static. Like there's nothing out there. So you have to ask yourself, who is willing to work out there? So we just have better treatment in a community setting than we do in an incarcerated setting. So the other thing that's really important about this is that when we started in the 1980s, when we started requiring treatment as a way to control these offenders, we realized that treatment actually can be effective when it's coerced. So in general, it's always going to work better. People that volunteer to receive treatment are always going to do better than people that don't want to go to treatment. That's that self-selection bias that we always talk about when we're talking about research methods. People that volunteer are always going to do better than people that don't volunteer. So a lot of times this is why we like a randomized experimental design, or at very least a quasi-experimental design, because most treatment requires a volunteer. So if you're comparing a group of people that volunteered for treatment compared to those that didn't volunteer, usually the ones that volunteer have something inside of them that we can't measure that makes them more motivated to change. But what we have noticed is that even when we force someone to go into treatment, we can still have positive results. So if you guys have ever watched Intervention, like the same thing always happens. When this person is confronted by their friends and family saying, hey, you have a problem, you need to go into treatment, they always fight it, kicking and screaming. They don't want to go to treatment. And then when you check back with them 6 months later, they're like, yeah, that was a great idea. I was really in a bad place. Treatment was a great idea. So treatment can be helpful when it's coerced. So this is a good thing right here. So we can use the power of the criminal justice system to force treatment on these people. It's always going to work better when somebody volunteers, but we can still have positive results when we coerce people to go into treatment. So this is where drug courts can be very helpful, because we can coerce people to go into treatment. And this other bullet right here, the difficulty of placing offenders in a treatment program, we can solve that with drug treatment or with drug courts, because in general, a lot of problem faced by people that are trying to receive treatment on their own is that there aren't enough treatment slots. And even if they are, people that have been arrested are not preferred clients. And if you're if you're trying to get into a private treatment program, they can deny you if you have a pretty significant criminal record or if you've got violent charges on there. But if we're using a drug court, if you're going through drug court, you are guaranteed a slot in a treatment program. So just in general, again, studies have indicated that people that go through outpatient drug treatment programs have significantly reduced recidivism rates. But we have to be cautious when we're just generalizing to all treatment programs. So remember, like I said, when we're talking about outpatient drug-free, we are mashing like thousands of types of therapy into just one sort of generalized treatment program. There are all kinds of differences when you look at the different types of outpatient drug treatment. Some therapies work better than others, especially if someone is considering a 12-step program to be outpatient drug-free. That's not really something that most experts would consider treatment. But in general, if you're giving someone any sort of outpatient drug therapy treatment compared to someone that's not receiving treatment, you're going to find better results. So who wants to turn this one into a policy implication? All right, Thomas, let's hear it.
I would recommend outpatient drug treatment to reduce recidivism rates post-release.
There you go. Simple as that. Great job. Okay, so that's all we have for this week. So just as a quick reminder, let's see, we've got Joseph. Let's see, there's Joseph. Jackie, I see Jackie, and Daniel Reeves. Do we have Daniel yet? I do not see Daniel. So I'll go ahead and
Ma'am.
Where? Yes.
So he's not in this class anymore because he thought it was a requirement, but then he found out that he wasn't required to take it, so he just dropped it.
Smart man.
Yeah.
Okay. All right. So we'll just have Jackie and Joseph play on Tuesday. And then for our last quiz, or not our last quiz, but the last round before the semifinals, we're going to have Evan, Roger, and Lucas. So you guys are on deck for the following week. But Joseph and Jackie, do not take your quiz today. Everybody else take your quiz, and Joseph and Jackie will play Jeopardy live on Tuesday morning. All right, any questions for me? All righty. Just as a reminder, you guys need to be working on your policy briefs. If you have questions or you want to do one-on-one sessions to get some help with that, I'm happy to do that. Just send me an email and we'll schedule a time to do a one-on-one Zoom, and we'll work on that together. If there's nothing else, I will see you guys on Tuesday morning. Everybody take your quiz today, except for Joseph and Jackie. You two don't take it, okay? All right, I'll see you guys on Tuesday.